Dear ladies and gentlemen, the next couple of minutes we will discuss conformers, which is a customized, individually made total knee arthroplasty, but it's also available as a bicompartmental or unicompartmental knee arthroplasty. And I've got experience with over the last 8 years. I think there are two levels of patient-specific surgery. One is using patient-specific instrumentation, but then you still use a standard implant. So actually you stop half the way. And the next step is actually having this patient-specific instrumentation available, but on top a patient-specific implant as well. So this is basically 100% of patient-specific surgery. Let's come back for a second to patient-specific instrumentation. There's a meta-analysis who has included 10 randomized controlled trials, and the authors did not find any difference between PSI and standard implantation. And there are other studies, high-level studies actually, who could not find any difference in terms of component placement. On the other hand, there are studies who have shown significant difference, like the study by Heiser, who has shown that femoral malrotation happens much more frequently, actually 10 times frequently, when you use standard surgical technique in comparison to PSI. So some of these studies, they have proven actually that the accuracy, or at least the rate of outliers, can be significantly reduced when you use PSI. However, as I said before, in patient-specific instrumentation, you use standard implants. But when you use a custom-made, individual-made arthroplasty technology, then you can actually really mimic the shape of the medial and lateral condyle. But there are some compromises as well, for instance, like the trochlea, which is not exactly made as a patient's trochlea is in real life. So again, but having the correct curvature of the condyle, you can conclude basically that there's more physiological tensions, for instance, in the PCL or in the collateral ligament, and this might improve stability and not kind of overstretching the ligaments where we find the nociception. There's a huge anatomical variability between the patients in terms of sizing and even of the medial and lateral femoral condyle, of the shape of the trochlea, of the angulation of the medial condyle, of the size of the tibia as well. So, and the implants which we have available, actually they can just average these kind of differences by using different sizes. But of course, when you make a specific implant for each patient, you can be have a much higher accuracy with the shape of the component in regard to the anatomy of the patient. We all familiar with a study by Michel Bernard actually could show that if you have some kind of overhang on the femur or tibia side, you have a significant impact on pain, couth, and range of motion. Michel Bernard, he looked into the correlation between component sizing and component overhang and clinical outcome. And this is quite frequently that you will find some overhang on the femoral or tibial side. And he could prove that if this occurs, the patient may complain about more pain or lower couth, or may have a lower range of motion. There's a very precise surgical planning, and these information, which you can see on the slide, actually the surgeon receives prior the procedure. So you know exactly for each cut how many millimeters you have to resect. And I think it's very essential that you check the resections of each step, because there is a tendency to undercut basically, and this may cause overstuffing and limitation in range of motion. This is probably one of the most important slides because it provides some information about the performance of the conformers prosthesis. When you see this, the first study is alignment it's very good. So there are a few numbers of outliers, even within 2, and not what we use normally as a reference, 3 degree, in regard to neutral alignment. The overhang, of course, is not an issue because they are patient specifically designed. This can be avoided, except during surgery, you're not precise with component placement. Kinematically, the kinematic has shown that the rollback is slightly improved from 1.2 millimeter to 4 millimeter. I'm sure there's a huge variation. And axial rotation is increasing by 2 degrees. But then you have to ask how much these differences really affect the clinical outcome. And the condylar lift up apparently can be reduced, and which of course shows you that ligament tension seems to be better when using the conformers implant. We have done a clinical study where we actually match paired 30 patients who received conformers with 30 patients who got a standard implant. And after a follow-up time of 3 years, we did not identify any difference in terms of knee score or function score. So far, we are still not able to give a strong evidence that this customized implants will show a better clinical and functional outcome, and we still haven't got the data about the survivorship of these implants in comparison to standard implants. However, what you have to consider is instability of jigs. So even if you have very precise jigs available, but if these jigs are not stable enough and it may cause some kind of deviation, it might bring a variation automatically. So then that's always a discussion, surgery currently is planned by the engineers. So does he really consider all aspects which a surgeon might consider when he sees CT or MRI? In patient-specific instrumentation, that has shown that there's actually no difference whether you use CT or use MRI. But still, when you use CT-based, you have to be aware that you have to be very meticulous removing all cartilage. Otherwise, you might actually under-resect the bone, and then it might cause an overstuffing. So even if you have such a precisely designed components, why we are not able really to improve clinical outcome and function significantly? And these are aspects which should be discussed as well. And one is the bone resection, for instance. We know that due to the deviation of the saw blade during the cut, there might be a variation of 2 millimeters. And we also know that the cut itself causes roughness of the surface, which might have an impact of 1.7 millimeters. So these two aspects already cause a variation of 3.7 millimeter during our surgery. The next aspect is the cementing itself. And you can see on the data that there occurs a variation of femoral and tibial implanting, even when you try to be very precisely doing your surgery. But these numbers we have to keep in mind. After we have discussed the precision in terms of our surgery, we should discuss the outcome as well, because in general, surgeons report good and excellent results in 85 to 90% after joint replacement. But in contrast, the insurance company, they report about at least 20% of patients are not entirely happy with the clinical outcome. But then you have to argue, what does not entirely happy mean? So who of us discuss with the patient what he can expect after joint replacement? And when you see these data, that 52% of them expect no functional limitation and 20% no limitation at all after surgery, then you can imagine these data are entirely unrealistic. And we might have improved the conversation with the patient and explain him in more detail what he can expect after surgery. I believe we should continue with customized implants in total knee arthroplasty because it's the best way to reconstruct the medial and lateral femoral condyla for the moment, and we are able to preserve the ligament tension, and we know that nociception and proprioception comes from the soft tissue, from the capsule and from the ligaments. And if we are able to restore the soft tissue envelopes, we might be able to improve knee function as well. Thank you very much.